Good evening, everyone. So thank you for joining the webinar, the first of its kind. The first. So thank you for joining the webinar, the first of its kind, a debate series, Controversies in ID. This series is sure to ignite your curiosity and stimulate meaningful discussions. In this webinar series, we will delve deep into important and thought-provoking topics in the field of infectious diseases. So during this webinar, we are exploring 4 key controversies that have sparked intense debates in the field of ID. So the ID fellows will present their perspective, articulating the pros and the cons of each issues. And these controversies lie at the heart of ID, and by addressing them head-on, we aim to shed light on the complexities and the challenges faced by the healthcare professionals and researchers alike. So I assure you that this webinar series will be captivating and enlightening experience, and a diverse range of topics and the expertise of our speakers will undoubtedly provide valuable insights and provoke engaging discussions. We encourage active participation from all the attendees. So your perspectives and questions will add depth and richness to our conversation. So prepare yourself for the series of riveting debates, enlightening presentation. So again, I would like to thank everyone for joining us on this exciting journey through the controversies in ID. So without any further ado, let me introduce the moderator of this session, Dr. Deepak Kumar, sir. So, sir is Associate Professor in the Department of Medicine and Infectious Diseases at AIIMS, Jodhpur. He is highly accomplished professional in the field of medicine and ID with a remarkable educational and extensive experience. With a passion for teaching and research, Deepak sir serves as the coordinator of the DM Infectious Diseases program at our institute. He also holds the position of Dean Assistant Research, contributing to the advancement of medical knowledge and fostering a culture of research excellence. Furthermore, he played a vital role as a nodal officer in the COVID-19 management. And his dedication to academic pursuits is evident in his various roles and achievements. In addition to the teaching and the administrative responsibilities, Sir actively engages in research and has been involved in several noteworthy projects, including ICMR, AMSP, OTAC study, WHO, COVID-19, etc. His research findings have been disseminated through various scientific publications with more than 70 publications and 3 chapters in national and international journals, with multiple paper and oral presentation at national and international conferences. Sir, over to you, sir.
Thank you, Akshatha. Thank you for elaborative acknowledgement, and thank you for the invitation. And I'm welcoming all the participants and the delegates and the speakers of today's interesting this webinar that is Controversies in ID. Akshatha, allow me to share the screen.
Not able to share the screen.
So we shall have a series of speakers in today's webinar, and one of the speaker will speak in the favor and other in the against of that particular topic, and the 10 minutes will be given to the each speaker. And after the 10 minutes, and we have 5 minutes for the rebuttal, and we have opinion poll before as well as after this Controversies in ID webinar. So our first topic, sorry, I'm not able to share the screen. Akshatha, you should share. So our first topic of today's webinar is preemptive therapy versus prophylactic therapies in the neutropenic fever. And for this topic, our first speaker is Dr. Nivedita Niranjan. She is working as a ID consultant in Global Hospital Chennai with an 3-year experience, and which she is going to speak in the favor of preemptive therapy. While our second speaker is Dr. Venkat Ramesh. He is working as a consultant infectious disease in Apollo Hospital, Hyderabad, with an 5-year experience. And he also completed this diploma in tropical hygiene with an top 10 percentile. So first we will start with the poll. Sorry, I'm sharing the screen. Sorry. So we can have audience poll on this particular VVox app. I think it is now visible to everyone. So we can have poll, and our I request audience to a quick poll in the favor of either preemptive therapy or prophylactic therapy, and we will have poll again after the completion of this webinar. So I request everyone to poll on either preemptive or prophylactic therapy.
So, people,
Hello.
sir, the polling is not set up. Please press enter to start. I
Uh,
hope everyone has no difficulty to join the poll. Sir, if you can put the previous slide again, we will restart. I think most of them have not joined the
Okay.
box.
So this is VVox, the VVox.app. Anyone can join, and I'll starting the poll. Now I have started the poll.
So just click on.
Yes.
So just click on vvox.app and you can enter this ID which is displayed on top to enter the poll. So you don't have to re-log in again and again. So once you register into this, so you will be getting the questions. So no need to download any app. Just click vvox.app in the Google and enter the ID. Or you can even scan that QR code which is present in. So slideshow and press delete sir to clear the previous polling results. You can have a repoll this time.
Yes.
I request all of you to join this.
I will share again.
I got the app, but not getting how to vote. Hello, sir.
Yeah. Now you can vote. You
Yeah,
got the app.
yeah, sir. Thank you.
Yeah.
Okay, please enter your response now. Okay, I think we can end it here, sir.
Yeah. So we are ending the poll, and what we have seen that most of the participants are in the favor of the preemptive therapy. So let's start our first topic, preemptive versus prophylactic therapy in neutropenia. As I have discussed, our first speaker is Dr. Nivedita Niranjan. She is working as the ID consultant in Global Hospital, Chennai. And our second speaker is Dr. Venkatesh Ramesh, and he is working as a ID consultant in Apollo Hospital, Hyderabad. So over to you, Dr. Nivedita, ma'am.
Thank you, sir. I'll share my screen.
Ma'am, please put it on slideshow.
Good?
Yes, ma'am.
Okay, so am I audible?
Yes, yes, ma'am. You are audible.
Good evening, everyone. Thank you so much, sir. So I'll be talking about prophylaxis in neutropenics. So usually when we say neutropenic fever, then I think it's more of a therapy than prophylaxis. So its prophylaxis is in neutropenics. So neutropenia is a condition where the absolute neutrophil count is way less than the normal. So when it's less than 500, it is going to be a severe neutropenia. And if it's mild and moderate, the counts are between 1,500 and 1,000. There are various causes which cause this neutropenia. It could be congenital or acquired, and a post-infectious causes bacterial or viral, drug-induced like linezolid, methotrexate, or even valganciclovir, and a few malignancies. This neutropenia is always a dynamic situation because the host factors and the condition which is causing this is going to be very important in deciding how to treat it. So that's why not all neutropenics, they are treated equal. So among these neutropenics, there is a subset of high-risk neutropenics. So who are these people who have a prolonged and a profound neutropenia? When I say profound neutropenia, it means, again, the absolute neutrophil count, which is less than 100 cells. And prolonged is the duration 7 to 10 days when the neutropenia is prolonging. And this is seen in a few conditions like blood malignancies and in those who receive remission induction and rescue chemotherapy. And in cases where the intensity of chemo is higher and when newer biologicals like dasatinib and all those are being used. And when compared with solid malignancies, these blood malignancies, they have a higher risk of neutropenia progressing to febrile neutropenia, especially in those who receive HSCT, post-HSCT, than in induction chemotherapy. This is a 5-year study which shows there's an increased incidence of complicated infections, more ICU transfers, and more mortality rate with post-HSCT. So usually people who are neutropenic, they have a high risk to progress to febrile neutropenia. And this phase of febrile neutropenia is more predictive of complicated bacterial infection or even fungal infections and the prolonged hospitalization, and which also increases the risk of mortality. So when we are talking about mortality, there's also, along with that burden, there is an economic burden, which is seen in these people who progress to febrile neutropenia. This study from 2006 from US, it shows an in-hospital mortality, which was 9.5% with a median stay of almost 11.5 days. And the cost involved was
Ma'am, you're not audible now. Are you connected?
I'm sorry. Yeah.
Ma'am, it has got disconnected, I think.
I think she got some signal issue.
There is some technical issues, net issues. Ma'am will be joining shortly.
Am I audible?
Yeah, madam. Yes.
Sorry, can I start from this slide?
Yes.
Yes. So the neutropenics are at high risk to progress to febrile neutropenia. And this is the phase which is highly predictive of a complicated bacterial infection and even fungal infections, which could lead to prolonged hospitalization and increased mortality. And along with this mortality burden, there's also some amount of economic burden for these patients in neutropenia. So this is a study from 2006, where the mortality was 9.5%. But if you see the per episode of febrile neutropenia, the stay was 11.5 days and it was 19,000 US dollars. So a similar study close to our country, when we see the mortality was 13.9%, with the cost involved is 999 US dollars. And this was definitely less when compared to the US and Singapore. But this could be because of the per capita income of that country. This is from Bangladesh. But when we see the US dollars, it's $37,000. So comparing, that was in 2006 and this is 2022, because of the time period and the inflation, this change. So we now see that there is definitely a mortality burden and an economic burden in these patients. So if there is an intervention which could avert this, that's where the prophylaxis comes into place. Prophylaxis, this has been divided into different domains like antibacterials, antivirals, and antifungal. But along with these, there are also vaccines, which could be like ring vaccination, where the family members and healthcare professionals who are treating the patient, especially for flu and for varicella, if they are selective, individual. And the colony stimulating factors, that one, in case if there is a risk, according to MASCC score, if there is a risk to progress to febrile neutropenia is 20%, this is advised, and immunoglobulins in primary immunodeficiency. So when we see the guidelines, most of the guidelines, they advise the administration of antibacterial prophylaxis only when post-chemotherapy is expected to be prolonged more than 7 to 10 days. And nowadays it's been known from broad spectrum action and anti-terminal action. Here, the CD index is the depth and duration of the neutropenia, which is being considered. So when we come to antibiotic prophylaxis, the fluoroquinolones, it's mostly ciprofloxacin and levofloxacin because of all the broad spectrum action what I've mentioned. And levofloxacin does have an extra strep viridans cover on patients with mucositis. So this is a Cochrane analysis of 109 trials with 13,579 patients for 37 years. Here, study compared the antibiotic prophylaxis with placebo or no intervention. And the outcome was definitely a reduction in the mortality rate and also a significant reduction in the occurrence of fever and documented infection. And also the risk of harboring resistant bacteria was statistically insignificant. Here, what we have to note is the number needed to treat. It is just 34. So how often do we come across this low number to treat in a healthcare interventions, and with also low risk of mortality? And these patients, neutropenic, are also at high risk for reactivation of viruses, especially from the herpes viridae family. So usually acyclovir is prescribed. And when it comes to CMV, there is always an unmet need for a safe and effective method of a prophylaxis here. And this was until recently, because the drugs used in CMV could pose a threat to myelosuppression or renal toxicity. Until recently, a newer and a novel drug like letermovir was introduced for prophylaxis. And a study has also shown in 2017, when letermovir was used against placebo, definitely this has a role in reducing the incidence of CMV infection in recipients of allogeneic hematopoietic stem cell transplant. This was well tolerated, and definitely there was less incidence of resistance to ganciclovir, which we are really worried in CMV prophylaxis. And then fungal prophylaxis, usually azoles, but again, it depends on the institution, their epidemiology, and the challenges what they face. This meta-analysis of 26 trials with 3,979 patients, when they estimated with the effect of antifungal prophylaxis, against the invasive incidence of invasive fungal infections, they observed a major outcome in the reduction of frequency of fungal infection, along with the reduction in the fungal colonization. And here also, you should know the number needed to just 22 hours of fungal infection. So all this talk, when we were talking about prophylaxis with various drugs and all that, definitely we would have been thinking about what about the emergence of a resistance bacteria or any adverse effects of these drugs. But all the studies that have shown until recently, these numbers are very insignificant. So we should not allow these to overshadow the benefits. C. diff, yes, I do accept. But then when compared to West, we do not it's only an evolving issue and require more data. A patient in neutropenic, if the prophylaxis, if the febrile, and also the financial burden. So if I'm going to ask if prophylaxis is the appropriate intervention in neutropenics, I would be asking myself, is this relatively safe? Is this proven to be effective? Is this a life-saving with a decreased mortality? Is this an established intervention which is advised by governing bodies, or is this cost benefit to the patient? If my answer to all of these questions is yes, then definitely I would rest my case here saying that prophylaxis is the appropriate intervention in neutropenics. Thank you.
Thank you, madam. Thank you for an insight for the prophylaxis therapy in neutropenic patient. Our next speaker is Dr. Venkat Ramesh. Sir, over to you. And I request all of the speakers to stick our strict timeline for the 10 minutes. Thank you.
Yeah.
Sir, am I audible?
Yes, sir.
Yeah, I'm sorry. Yeah, can you hear me now?
Yes, sir. Yes, sir. Now you can share your screen.
Yeah, there is some issue with that.
And I also request all of the participants to keep your mic mute.
Yeah. One second, please. Just
Yeah.
Yeah. Yeah, you can see my screen, right?
Yes, sir.
Yeah, okay. So I will be speaking for the motion, preemptive therapy in febrile neutropenia or neutropenic fever. So if you look at what we mean by preemptive therapy, it means to take a measure against something possible, anticipated, or feared. And if something is preemptive, it is done before other people can act, especially to prevent them from doing something else. Or it can also mean having the power to prevent from happening or taking place. So really what we're trying to prevent, what we're trying to preempt in febrile neutropenia is morbidity and mortality associated with the disease. So when we look at preemptive therapy in the context of the other forms of treatment, that is prophylaxis, empiric, or targeted treatment, preemptive essentially means that laboratory tests or radiographic signs are conclusive of infection, but there is no definitive proof by histopathology or culture, as opposed to prophylaxis, where there are no attributable symptoms and signs, and empirical, where there are clinical symptoms and signs of infection, but there is no pathogen identified. And targeted, of course, means there is a definite proof by histopath or culture of pathogen and invasiveness of disease. So it in medical parlance, it involves the initiation of therapy based upon screening with a sensitive microbiology assay, either antigen detection or a molecular assay, to detect the presence of a putative pathogen or early subclinical infection. The key word here is subclinical infection, where the patient may not have symptoms or signs of clinical involvement. Patients whose infections are detected using a preemptive approach are treated to avoid progression to invasive disease. Now, this is a study where they kind of looked at what, which will demonstrate what preemptive therapy means. So you can see here, galactomannan testing was done twice weekly. So let's say now a patient has febrile neutropenia. The protocol that was followed in this study was a single positive galactomannan or PCR test, which led to high resolution computerized tomography of the chest, and then antifungal treatment if criteria are met. Whereas if the patient had serially negative tests and was afebrile, then no CT scan and no antifungal treatment, but had persistent febrile neutropenia with a negative serial galactomannan and negative PCR, then they did go in for an HRCT of the chest, and if that was abnormal, treat for possible IPA, or if that was abnormal, if that was not showing any abnormalities, then no antifungal treatment was provided. So this is another study where they looked at another paper actually, where they looked at how to define preemptive treatment. So there is a little bit of a difference here. As Dr. Nivedita had pointed out, when you talk of prophylaxis, you're essentially talking about asymptomatic patients. When you're talking of preemptive therapy, there is really nothing like preemptive therapy when it comes to antibacterials or antivirals, perhaps, because febrile neutropenia is a medical emergency. You will start intravenous antibiotics within an hour of presentation. But when you're talking about invasive fungal infections, there is this approach called a preemptive approach, where you look for radiological signs suggestive of invasive fungal infection or a positive screening test, and by definition there will be no definite histopathological or cultural identification. Okay, now what is the data which supports a preemptive approach? So this was a study which looked at galactomannan and PCR versus culture and histopath for detecting use of antifungal treatment for invasive aspergillosis in high-risk hematological patients. So they did divide patients into two groups. When they used the prophylactic, the empiric approach, when an invasive fungal disease was suspected for whatever reason, cultures of blood, urine, and sputum and feces, if clinically indicated, and HRCT of the chest was done. Bronchoscopy and biopsy was done as per the institutional protocols. And empirical treatment with antifungal drugs was recommended while patients were undergoing these investigations, and was continued, de-escalated to prophylaxis, or it was changed depending on the test results. So this is essentially empiric treatment. And in the prophylactic group, this is the same study that I alluded to earlier. This protocol was followed. So, and they looked at 240 patients, divided them into 122 and 118 groups, 122 and 118 in each group. And they found that 39 patients in the standard diagnostic group and 18 in the biomarkers group received empirical antifungal treatment. And the important point here is that it reduced the use of empiric antifungal treatment, use of Aspergillus, galactomannan, and PCR. So please remember that even in this case, even if you find abnormalities on computerized tomography, you would still consider it empiric treatment because it's not definitive. So that's a little bit of a nuance that needs to be understood. But otherwise, it reduced the use of empirical antifungal treatment. Then this was another study which looked at empirical versus preemptive treatment. And here the empirical treatment was defined as antifungal treatment of patients who have persistent or recurrent fever. Preemptive was clinical imaging or galactomannan antigen evidence suggesting fungal disease. So by intention to treat analysis, survival was more or less similar. It was within the 95% confidence interval. And proven or probable invasive fungal infections was most common among patients who received preemptive treatment. So what it does show is that when you go for a preemptive approach, you are able to detect invasive fungal disease more easily. And you're decreasing the cost of antifungal drugs. And this was another study here, which was a Korean study from Singapore, which looked at this same matter. And they found that the survival was the same, but the preemptive approach saved about 11 and 14% respectively in the intention to treat and evaluable episodes arm. So it may reduce empirical antifungal use without compromising survival in persistently febrile neutropenic patients. And this is just a summary of the studies that have looked at these two approaches. So what are the disadvantages with an approach that is other than a preemptive approach? So you will be over-treating patients with potentially toxic and expensive antifungals. And I'm really not a big fan of antifungal therapy without biomarkers and imaging, especially in an era. We are in the year 2023. We have access to excellent diagnostic tests such as galactomannan antigen, beta-D-glucan, and excellent imaging modalities, which are quite freely available. So what I really do in my practice is, okay, so this is another slide again, just trying to re-emphasize what we mean by prophylaxis, empiric, preemptive, and specific treatment. So prolonged neutropenia with fever, you would consider empiric treatment, empiric antifungals. But if you also have lung infiltrates or a biomarker that's positive, that would be preemptive therapy. So I use the middle path. So if somebody has prolonged neutropenia plus fever, I would go for an approach which kind of synthesizes both the preemptive and empiric strategies. So we do order galactomannan and beta-D-glucan depending on the clinical circumstance, and simultaneously proceed for imaging of the chest and paranasal sinuses, and start empiric antifungal therapy at the same time. And if the galactomannan is negative and there is really nothing on the imaging, then we discontinue the antifungals, because our turnaround time for galactomannan is, it's done only twice a week on Tuesdays and Fridays in our center. So sometimes we don't do the test every day. So our turnaround time is a little long. So that's why we don't go by a purely preemptive approach. But in centers where you have access to daily galactomannan testing, I think that's still feasible. So I would say use the middle path. Use an approach which synthesizes both. But if you ask me, if you have access to daily galactomannan testing and daily beta-D-glucan, perhaps you can use just a preemptive approach and wait and watch. There's really no harm, because the probability of an invasive fungal infection is quite low if you have a negative biomarker and a negative imaging. So yeah, that's really my take-home point is preemptive therapy is the way to go. But sometimes when you don't have access to rapid turnaround time for serum biomarker testing, follow the middle path like we do. And that gives us tranquility, stability, and ease. Thank you.
Thank you, sir. Thank you for enlightening regarding this preemptive therapy. So due to shortage of time, we have 2-minute rebuttal. So Nivedita ma'am, if you want to say something. Please unmute yourself. Yeah.
Thank you, Venkat sir. That was really great. Talk on preemptive and empirical. But still, I think when preemptive is considered, this is diagnostic driven. And definitely the cost incurred with that as well, with the imaging and all that do add on to the patient when compared to the prophylaxis. And as you rightly mentioned, the logistic issues, the turnaround time in most of the institutions, that could also be a factor in delaying the treatment. So all these things, I think, would favor a prophylaxis. And even the imaging and all that, maybe in neutropenics, we do not get the image of a normal immune person in neutropenics.
Thank you, ma'am. Sir.
Yeah, so I agree. I'm not against prophylaxis, but I am in theory against treatment of invasive fungal infections without any diagnostic modalities. So we do know that the sensitivity and specificity of Aspergillus galactomannan in febrile neutropenia is quite decent. Unlike in patients who are non-neutropenic, if you look at various studies, you have decent sensitivity and specificity, and you can look at the negative predictive value and positive predictive value in your center and make an informed decision. And on top of that, when you have imaging, which is quite characteristic, I think that it's kinds of gives you a direction, because in patients who are neutropenic, if you don't have an answer, the longer the diagnosis is, the delayed, the increase in the risk of mortality. And also invasive fungal infections do have contribute to significant morbidity and mortality in patients with febrile neutropenia. So I am all for prophylaxis, but I cannot discard the fact that preemptive approach has a lot of value, especially in a country like India, where the burden of fungal diseases is quite high. And similarly, I'll just make one point, that you can kind of sometimes, if you have a negative galactomannan, negative beta-glucan, but you have imaging suggestive of invasive fungal infection on paranasal sinuses or chest imaging, then you will be thinking of mucor. So even that, when you do both the things, it gives you a lot of clues, and your approach kind of rapidly changes. When your suspicion for mucor is there, the voriconazole doesn't have activity, and you can switch to a lamb with maybe posaconazole or isavuconazole. But you really have some direction when you push for a diagnostic modality of imaging or a serum biomarker.
Yeah, thank you, sir. As an extensive discussion regarding this preemptive and prophylaxis, so we can say we should have the middle path.
Yes.
We have to decide the patient is actually very sick, then we have to start empirical or on aggressive therapy. If patient is not very sick, we can use this MASSCC scoring to score the patient, and we can decide on the case-to-case basis. And actually, both the approach are actually very much helpful. Thank you, ma'am, and thank you, sir, for this enlightening talk.
Thank you
sir.
for having us.
Thank you, sir.
Thank you, sir.
Okay. So we will start the second talk. So before second talk, we will go with the poll. I think I request all of the participants to again participate in the poll after the talk. Yes, the poll has started. So after the poll, we will going to be discuss our second topic. Our second topic is therapeutic drug monitoring, essential or dispensable. So I am ending the poll. Again, most of the most of the participants are in the favor of preemptive therapy rather than the prophylactic therapy. So I request all of these participants to again before poll before debate poll regarding the therapeutic drug monitoring. So I have again started the poll. I request all of you to do poll, and then I will shortly introduce the speakers of the second talk, TDM, essential or dispensable. Okay, so I'm ending the poll. And most of the participants are in the favor of TDM essential. So our first speaker is Dr. Siddhant Sethi, and he's infectious disease fellow pursuing in the PD Hinduja Hospital, Mumbai, and he has published posters in the SITSCON 2021. He has awarded for the best oral presentation at SITSCON 2022, and also completed this diploma in DTMH. And he's also part of the Indian COVID guideline formulation group. And he also have oral presentation in the ECMA 2023. And he's going to speak that therapeutic drug monitoring is essential. And our second speaker is Dr. Akshatha, and he's pursuing the DM infectious disease from AIMS Jodhpur. And she has published 10 chapters in the essential antimicrobial stewardship book, and also received the various grant from the IDSA and ECMED and ESAM. And she is quite enthusiastic regarding all the type of webinars and presentation and conferences. And she also published 10 papers and 10 abstract in various national and international journals. So I request our first speaker, Dr. Siddhant Sethi, to start. Dr. Siddhant, am I audible? Yeah.
Yes.
Yeah. Yes.
Okay. I hope my screen is visible.
Yeah.
So yeah, so that poll is half my job done. So let's get on with the other half. So I'll be speaking for the necessity of TDM. And to me, it doesn't even seem worth a debate. So let me show you how. So why TDM? What are the problems we are facing right now? Primarily, drug resistance. It's the modern day problem. So when you expose bugs to subtherapeutic dose of antibiotics, you're virtually breeding resistance. So as goes a popular song, what doesn't kill you makes you stronger. This is happening to our bugs as well. Also, antibiotics are getting more toxic by the day. Critically ill patients have altered PKPD parameters, so just cannot predict the drug levels, the efficacy of antibiotics in altered renal states, in altered hemodynamic states, etc. Now we're entering an era of personalized medicine. So one size does not fit all, and we need to adjust dosing as per individual needs. So TDM is essential for that. And last but not the least, to ensure compliance in long-term therapy. So I'll get on with my presentation by sharing a few cases. It's not going to be very didactic, it's going to be more practical. So this is a patient we've recently treated. She's a 55-year-old female with pH positive ALL on DSM-90 severely immunosuppressive chemotherapy. She develops febrile neutropenia and then presents with right-sided facial puffiness and periorbital pain with sinus tenderness. So we did an imaging which showed, as you can see, right-sided maxillary sinus mucosal inflammation hypertrophy, along with inflammation of the mucus, bilateral middle and lower turbinate, and even the lung showed a healing. So now we're thinking of an invasive mold infection, probably aspergillus. And when we went in and a test was done, the tissue grew both an aspergillus flavus as well as a mucor rhizopus. When we hear mucor, the first thought that comes to mind is amphotericin. And as we have seen through the post-COVID mucor epidemic, the toxicity, the cost, and availability all are very difficult to manage. So this patient was started earlier on empiric and later on it was directed isavuconazole. And a test was done with good source control. Okay, no amphotericin was given to this patient and she improved. And we did a TDM which showed a good isovo level, where experts say that when you target severe infections on sick patients, a level of 8 to 10 is good to ensure adequate activity against mold infections completely. And this was supported by a paper which came last year during the COVID mucor epidemic, where without amphotericin, because of its availability, we went against the usual norm of using amphotericin and just managed with triazoles. And this was backed by solid evidence of TDM. And only then good TDM levels were achieved, patients had a good outcome. So all this nephrotoxicity and all the other issues were bypassed. So what are the issues with triazoles? They have bad absorption by GI tract. 2-3 years back, when there was no tablet posaconazole, when you were using syrup posaconazole, it was impossible to attain blood levels. It was a nightmare. Same goes for our voriconazole and tablet isoconazole. Sick patients have altered PKPDs. We've discussed this already. These drugs have multiple drug interactions, starting from your PPIs till rifampicin, till protease inhibitors, everything. Highly hepatotoxic drugs. And last but not least, QT prolongation. So how do you ensure that they attain good levels? They are not disturbed by altered PKPD and do not cause toxicity. All 5 problems, just one solution, that is TDM. And this is backed by mycologists who believe in this thing, even if you don't take my word for it. So we'll come to the second case. She is a 66-year-old female, diabetic with early DKD, mind you. She was admitted a few months back with fever with headache for 3 to 4 days and altered symptoms in 1 day. So clinically acute community-acquired meningitis. So she came in with bad GCS with neck stiffness positive, hemodynamically unstable. She was stabilized, intubated, started empirically on ceftriaxone, vancomycin, dexamethasone after sending cultures, and the CT green was suggestive of meningitis. And we go ahead and perform a lumbar puncture, which shows severe hypoglycemia and highly elevated proteins with gram stain positive, and the biofire detects a pneumococcus. And the blood culture eventually grows a stress pneumonia. The CSF did not show anything. So this looks like a penicillin susceptible Streptococcus, but mind you, when you extrapolate this to meningeal breakpoint, the benzyl penicillin MIC of 1 is resistant and ceftriaxone MIC of 1 becomes intermediate, the susceptible breakpoint being 5. So in this case, vancomycin is the drug of choice. So what does IDSA say about vancomycin dosing? They suggest giving a loading dose of 20 to 35 mg per kg. This is a huge dose, okay, followed by a maintenance dose of 15 to 20 mg every 8 to 12 hours. So anyone who's practiced clinical medicine and used vancomycin knows that we just cannot use these kind of doses in our patients. We always have the problem of AKI. And this patient was a early DKD patient, so we just could not afford losing the kidney. So can we use these guidelines in our patients? The answer is a strict no. So at the dose of 1 gram twice a day, the patient was not improved. At that time, we thought of doing a TDM, and we found that the trough level was subtherapeutic. Also, when we give vancomycin, we are aiming a trough level of minimum 10 to 15 in non-endocarditis patients, and for endocarditis, we are aiming a level of 15 to 20, ideally. And so after optimizing the dose to 1.5 gram PDS, she now comes with a tough level of 13.6 with clinical improvement. And mind you, the important thing is she did not have any nephrotoxicity during this period. So we saved the kidneys as well as achieved a good therapeutic outcome. So the drugs which have a very narrow therapeutic index where suboptimal doses do not give any clinical efficacy and supratherapeutic doses have not very toxic, and we have a very narrow window of opportunity where these are the areas where TDM is the most useful, like vancomycin, like aminoglycosides, very important, 5-flucytosine, who have used in a clinical practice, and thiazoles, except fluconazole. Also, we have the problem of non-linear kinetics with a few drugs, where even a small dose escalation will lead to a disproportionate rise in the serum concentration and leads to bad toxic side effects. For example, voriconazole, triflusulfin, penicillin, and amoxicillin group of drugs. And there's so much of literature surrounding the efficacy, the benefits of TDM that I would not go into details of each one of them, but I think I have made my point. And TDM is being done across the world for so many antibiotics, starting from teicoplanin to aminoglycoside to voriconazole, rifampicin, isoconazole, isoniazid, posaconazole, isovu, going outside the purview of antibiotics to methotrexate in cancer patients, anti-epileptic. It's a time-tested dogma for the TDM has been used extensively for epileptics with anti-epileptics with outcomes, with digoxin, and the end tacrolimus in our post-PPI patients. So ID pharmacy, the entire branch is focused around adequate individualized drug dosing, and TDM is a huge part of their practice. So any argument which says that TDM is actually not essential is actually underplaying their role in our patient care, and really they are our backbone. I understand no technology is perfect, no system is perfect. This comes with its series of limitations. TDM is expensive. It's not available everywhere. It's a difficult technique to standardize and to interpret. The expertise to interpret and to perform these tests is quite limited. Thankfully, our institute has it, and so we get to use it very often. It is difficult to ensure tissue level concentration based on a blood level, also another limitation. And again, to coordinate the sample collection time, the trough level has to be taken 15 to 30 minutes prior to the dose, and peak level has to be taken 2 hours and 2 hours after, 6 hours after the peak. However, even if there are limitations, the benefits far outweigh the limitations in this case. And we have to work on this to make it a widely available technology. Okay, and any argument disreputing TDM is actually like the violinist on the Titanic. Will probably sound good, but the ship is sinking anyway. So this is my time. Over to the moderator. Thank you.
Thank you, Dr. Siddhant. Yes, excellent. We require the TDM. I'm also a TDM pro person. Now I request Dr. Akshatha to present regarding this TDM is dispensable.
Okay, I hope I am audible and my slides are visible.
Yes, go ahead.
Okay. So again, I thank, and again, as an ID fellow, I cannot be totally against TDM, and obviously I will not be talking about why TDM is not necessary. I would like to rather highlight the pitfalls and various limitations of the TDM. And actually, Siddhant made it my job a little easier by highlighting few important points of the limitations. So let's start. So there is black in the black, there is some white, in white there is some black, and in wrong there is some right, and in dark there is some right. So there is always two sides to every story. So all the rosy part has been described by, has been showed by Dr. Siddhant. So TDM has been there since more than half a century, and even in antibiotics, and traditionally it was focused to limit the toxicity and mostly on antibiotics like aminoglycoside and vancomycin. Now it has expanded to include ATT as well as antifungals. So when you look at the TDM requirements, so the requirements highlight the various limitations. So first requirement, it requires clinical capabilities, analytical facilities, and trained healthcare personnel. Second, it requires expertise in bioanalysis, pharmacokinetics to interpret the drug concentration and make the pharmacotherapeutic recommendation. Third, it requires reliable TDM service, which relies on rapid, accurate, and precise analytical assays. Fourth, proficiency testing program, that is the quality assurance. So can we guarantee all of these? Point is the cost effectiveness. Monitoring the therapeutic drug is expensive because of various equipment, supplies, technical experts which we need to hire, and the cost of TDM to outsource also is very quite expensive. It is rupees around 4,000 to 5,500 per drug per time, and again this cost varies depending on drug to drug. Point number 2, is it practical and accessible to all? So ideally the TDM should be precise, accurate, and highly selective for particular drug, and turnaround time expected is less than 8 hours and preferably shorter or within the same day of the sampling. And the various technologies which is available for TDM include your first initially we had radioimmunoassay, then immunological assays, the LCs and LS mass spectroscopies as well as biosensors. The immunological assay is the most commonly used, and there are various commercial kits which can have rapid results, but the standardization and calibration is not very easy. Then next we have what we call as LSMS, which is commonly used out HPLC methods. Again, these technologies you can individualize or you can have flexibility with various drugs, but this technologies is not available in all the labs, and turnaround time for this is quite more, that is 24 to 96 hours, and it will require an expert to interpret the results or do the test. Then newer ones which is emerging is the biosensor. So this one it has available as point of care, but again this is not available widespread as of now. And none of these currently available methods adequately distinguish between the bound and the unbound fractions of the antibiotic. And setting up TDM services is expensive. There is limited economic resources or minimal financial support which is available. High cost of acquisition and maintenance of these high-end instruments. Lack of commercially available test kits for most of the commonly like even more the drugs like linezolid may not have the commercially available test kit to do the TDM, even if you want to do that. Lack of highly trained personnel and limited proficiency testing programs, and even what you consider as appropriate reference materials is not available. Point number 3 is the quality assurance. So regular quality assurance is required, that is proficiency testing. So proficiency testing means you send the same sample to 2-3 different labs. You are expected to get the same results. So what is the proficiency or quality issues in this? So there is marked difference between even different methods. Then there is scarce data availability based on the difference in the genomic background of the local population. And as we all know, in India, we have various pharmaceuticals and various generic formulations which is available, which can again play a difference in attaining the levels. And lack of appropriate drug concentration reference ranges also. Point number 3 is the sampling issues. Proper timing is the essential tool of TDM, and ideally free drug concentration should be measured. And one more issue is, as we all know, in the critically ill patients, we may have to we give the empiric loading dose, and the TDM is not defined for that dose. And ideally, the first TDM should be measured at the very first dosing, and then we'll have to repeat it. And again, the different antibiotics have different short half-lives, and defining the best sampling time is problematic. And this was a small study which was done in Oman, where they have looked at the appropriateness of the sampling time, and they have seen that almost 65 to 70% of the patients had inappropriate sampling time. So which antibiotics to monitor, and the tedium evidence is there for aminoglycoside glycopeptides and some of the beta-lactams, linezolid, as well as antifungal, but others like polymyxin, daptomycin, fluoroquinolone, cotrimoxazoles, and your antivirals, there is currently no data. Number 5 is issues with the methods used for this monitoring. So once you have done the TDM and you have attained, you have got some levels. So how are you going to adjust the dose? So first method, the commonly used method is you compare that level with the single level against the therapeutic target range, and you adjust the dose, you increase the dose or decrease accordingly. This is most commonly used, but this is least accurate, and it is not defined for all the drug, and this is all based on the plasma concentrations only. Second method is the dosing nomograms, which integrates the function, and this has better accuracy. And but again, this has a limitation. This will require your expertise of the ID pharmacists, which is currently not available everywhere, as well as whenever you are looking at various factors which can be factoring in together for the PK/PD parameters, like more the creatine clearance as well as the weight, it is not able to, we can't have a single dosing nomogram for that. Point number 6 is lack of clear therapeutic range. So what concentrations are you looking for, and where it should be there? So when, as we all know, the most interaction between the antimicrobial and the pathogen is site specific. Okay, so but what we are doing in the TDM is plasma concentration, and we are taking this plasma concentration as a surrogate for the concentrations at the actual site of infections. And as we all know, the antimicrobials are unevenly distributed, and some attain very high levels in the plasma. So what you are, in the tissues rather than the plasma. So what you are seeing in the plasma may not reflect on the actual levels which is achieved. Point number 7 is dosing adjustment. So how to do the dose adjustment? So single value of TDM is seldom useful. So we have to repeat the again after 1 to 2 days for most of the drugs, or to see whether it has been achieved. Again, this will add to the cost. We'll have the factor of TAT as well as the availability. So who will do the dosing adjustment? A recent study have shown that a dedicated expert, that is pharmacological advisor, is required, that is an ID pharmacist, and again which is not available. Then there is no clear definition on how doses should be adjusted in complex ICU patients, and many TDM studies assume a linear relationship, but in ICU patients these are always dynamic. And what about TDM in critical care patients? We don't know whether we are achieving high probability of target attainment in the antimicrobials is beneficial, and recent trials have not shown any great significant effects on the mortality. And as we all know, the PKs in the critically ill patient can be different. So this was one of the review of the meta-analysis of the carbapenem therapeutic drug monitoring in critically ill patients, which showed there was no difference in the mortality as well as microbiological eradication, and in fact it increased the duration of the ICU admission. Then early TDM protocol is not established. That is the golden hour period, what we call the, we can't send the levels, and we go for empiric loading dose. So the concept of the early TDM protocol is not established, and there is always a risk of overcompensation. So over-reliance on this TDM may lead to unnecessary dose adjustment solely based on the drug levels, and this could lead to suboptimal therapy and increased drug effects. Next, patient factors. Does only the drug levels influence the outcome? Definitely no. So just the drug levels will not capture or predict your adverse or effects or the outcomes. The adverse reactions can be due to various other factors like patient susceptibility, concomitant medications, underlying medical conditions, etc. As well as the effect or the outcome can be differed based on the pharmacogenetic, that is the genetic variations in the drug metabolism and the response of the patient. So summarizing, this is a summary slide which I am showing. So the various pitfalls in the TDM, which I have talked about, is one thing is in the sampling, appropriate sampling, storage, and shipment, the method as well as the TAT, the turnaround time, who advises on the results, what are the targets we are targeting, as well as all other factors like patient as well as the therapy related factors. Is it a necessary event? So this one study looked at the it looked at the inappropriate vancomycin therapeutic drug monitoring in hospitalized patients. So this is a very interesting study which I got when I was looking for the literature. So here you see that they have done the intervention before they have done some intervention, that is the education of the pharmacy as well as healthcare workers so that they send appropriate sample or the inappropriate TDM is avoided. So you can see in prior to the trial, it was around almost 90%. Post trial, post the intervention, it has reduced, but they have commented that by giving this education, there was significant improvement in clinical practice. However, the results was short-lived. So I would like to highlight in this. So TDM in a patient, in a person's hand who has little knowledge about what to do with the value is like, we have a common saying in Kannada that is Mangana Kaili Manikya. That is, you give a diamond to a monkey, you know what it will do. It will not realize the importance. So concluding, these are my points. And finally, I think we have to currently emphasize on optimizing the PKPD-based dosing, appropriate use of antibiotics and practice guidelines, and for nurturing interdepartmental collaboration as well as education rather than blindly relying on TDM. So I rest my talk here. Thank you.
Thank you, Akshatha. You have pointed out valid points that it is not possible for the all. So we have a short time for rebuttal. Dr. Siddhant.
Okay. Can I present another case?
Yeah.
I'll take 2 minutes. Yeah.
Yeah.
Okay. Okay. So I'm coming to our favorite and the national favorite disease, TB. So this is a 52-year-old female in a TB hotbed of Mumbai, Dharavi's stepsister, Govandi. She came with a swelling over the right collarbone and along the neck for 2 months, low-grade fever for 2 months, loss of appetite, loss of weight for 2 months. So only 4 differentials, TB, and TB. So she was evaluated at the government center of SNEC was done, gene expert, G4, older mechanism, same positive, reflexive negative, started on government protocol, FDP, 3 tablets per day. She had no improvement of symptoms despite being sensitive to it. She had worsening. And when asked about compliance, haven't missed a single pill. So what were the differentials at this point? If you look at the lymph node, it was about to burst, a sensitive TB not responding to category 1. So a differential came out to be, is that NDR TB not picked up or other heterogeneous populations? Is there an alternate pathology like lymphoma we are missing out? Is it a paradoxical response? And is it inadequate treated TB due to non-compliance? So she can claim complete compliance. So that was virtually ruled out. So when she came to us, we did a biopsy and which showed the gene expert also showed detected high with more resistance detected, and LPA ruled out resistance, second line LPA ruled out resistance, and even the histopath was also mycobacterial etiology, no evidence of lymphoma. So now 3 differentials get stacked out, and we came to the differential of paradoxical response. So just when we were about to hit her with steroids, we thought of doing a TDM and seeing that both INH and rifampicin levels were very, very subtherapeutic. So now when we inquired, because I haven't missed a single pill, I have taken all the tablets regularly after breakfast, and the government program is advocating taking all the pills after breakfast to ensure compliance. And this is something that's happening at a national level. So we just split the tablet. We didn't even do such this. We just split the tablet, gave her individual dosing, and we attained good therapeutic levels of 3.7 and 14.7, and she made a complete response. And she took ATG for 6 months, and she was doing well now. So in a review of TDM for ATT, especially rifampicin, we have found that when you give it in combination, the risk absorption is altered. Okay, and even in disease states like diabetes, HIV, CKD, we have poor absorption, and it's the most important AKT drug there is, and we are misusing it so much in combination. There's so much of data that combination therapy will lead to malabsorption of the rifampicin and INH. So even I conclude my talk saying at SITCON next month we have a talk on how to do TDM for APT, and it will be an interesting talk by my teacher, Dr. Sunawala. Please attend, and everyone have a good evening. Thank you for the opportunity.
Thank you, Dr. Siddhant. Dr. Akshatha.
Yes. So as indicated in, I have few points. So first is in this recent case TDM in ATT. So I think simple questioning the patient, like asking for whether how he is taking, would have saved him the TDM. And after that also we have seen that like we didn't have to do anything else apart from advising rightly. So maybe I'm not totally against TDM, but again, these are the important points. We have to optimize the PKPD of the patient, like do give the appropriate antibiotic for the appropriate indication. And then even after optimizing all the condition, if there is no response, maybe we'll have to go to and we can rely on the TDM. Thank you.
I think it is an excellent discussion. So in conclusion, we can say we have to do the TDM of some drug, as Dr. Siddhant said, all the azoles and especially anti-tubercular drug. And when you are not getting the response and the vancomycins, we should do the TDM. And so it is an expensive, not available everywhere. There are some disadvantage to dose adjustment. So we do not do for the every patients, but for the specific patient, or sometimes the patient is not responding, especially patient on ATT or vancomycin or patient on the azole. We recently encountered one patient who is receiving azoles with the, especially when patients are taking ATT, there's a significant drug to drug interaction. When you found that a patient is taking a lot of drugs, then you should go with the TDM. Otherwise, it should not be done in every patient. Thank you. Thank you for this excellent talk. So we'll go with the our next discussion, and our next discussion is so sorry, we can go with the poll again. Post we can enter in the poll. So post debate poll again, I request all of the audience to poll. So it is essential or dispensable. And after that, we will go with the next topic. So our next topic is quite important, that colistin, should it be discarded or is it still indispensable? With the increasing incidences and prevalences of multi-drug resistance bacteria, and we have left very few antibiotics to treat these MDR bacteria, colistin is one of the important antibiotic. But the as we have discussed, the narrow therapeutic index and a lot of the side effect make it very difficult to use and poor response. So we'll discuss in the next debate, and I'm ending this poll. And yes, now the audience is in between the 50-50. We should do in some patient, but not all the patient. So I again request to enter in the poll of the colistin. Should it be discarded or indispensable? So I request all of you to the poll. After the polling, I will briefly introduce the speakers. I'm ending the poll, and most of the audience are in the favor of indispensable. Definitely, we have very few drugs available to treat MDR bacteria. So our next speaker is Dr. Hari Prasad Srigiri. He's pursuing the DM infectious disease, and he's ID resident in the clinical infectious disease department at AIIMS Raipur. And he worked as the medical officer and physician in various armed force hospital. And he's going to speak colistin, should it be discarded. And the second speaker is Dr. Santhanam N. And he is also pursuing the DM infectious disease at AIIMS Jodhpur. And he awarded a quiz winner in SITS PG quiz, and he had 4 publications. And attended or presented a poster in the 3 international conferences. So I'm stop sharing and I'm giving the platform to Dr. Hari Prasad. Over to you, Dr. Hari Prasad.
Sir, am I audible, sir?
Yes.
Yes, sir. I will share the screen.
Yeah.
Is my screen visible?
Yeah. Is screen visible? Make it on slideshow.
Yes, sir.
And you can start presentation. Yeah.
Yes, sir. Thank you so much, sir. I also use this drug on and off, so it's very difficult to convince all the people, but I will try to make this thing so that the other drugs can be brought into the market at least. So just a few words about cholesterol. Cholesterol, these are the lipopeptide antibiotics which have good activity against many gram-negative bacilli. And after its initial discovery in 1947, they were actually withdrawn from the market, and then it re-emerged into the market because of the growth of this MDRO, gram-negative bacteria, and the superbugs, and lack of newer drugs. And these are recommended by many guidelines as the last line defense for managing this superbug. And these drugs, both colistin and polymyxin B, share similar chemical structure. Only they differ in one amino acid position at number 6, and they have similar antimicrobial spectra and the resistance mechanisms also. The issues are only colistin is administered as a prodrug, but the other polymyxin, that's the polymyxin B, is administered as the active drug. And this exact mechanism of action
Dr. Hari Prasad, we lost you. Your voice is not audible. Dr. Hari Prasad, you are not audible. Dr. Hari Prasad, your voice is not coming. I think Dr. Hari Prasad lost the connection. He will be back in a minute.
Am I audible, sir?
Yeah. Yes. Go ahead. Your voice is not coming clearly.
Okay. One second, sir. Sir, now am I audible, sir?
Yeah, yeah. Now you are audible.
Sir, 1 second. Sorry, sir. Even from the first screen, I was not audible, sir.
Now you are audible.
Yes.
Start.
Yes,
Start sharing.
sir. So,
Yeah. I think there's a problem in some connection. So we are losing your voice sometime.
sir, now is it?
Now
Now
it is your, yeah, you are audible, but your PP, you have stopped sharing to start sharing. Yeah.
Now my screen is visible and I'm
Yeah.
audible, sir?
Yes, yes. Go
Okay,
ahead.
sir.
Yeah.
Sorry for the interruption. So we know that this colistin and polymyxin B. These are the lipopeptide group of antibiotics, and they cover against the gram-negative bacteria. And they after it was discovered in 1946, then it was stopped because of its toxic profile, and then it re-emerged in the market for reuse because of the development of this multi-drug resistant gram-negative organisms and lack of newer drugs. And many guidelines, including IDSA, recommend polymyxins as a last line defense mechanism for management of these superbugs. And both colistin and polymyxin B have similar chemical structure, excepting at one amino acid position, that is at position 6, and they have similar antimicrobial spectra, and they have same resistance mechanism. Colistin usually is administered as a prodrug, that is colistin methane sulfonate, which is a polyanion at a physiological pH, and this has to get converted into the active form, that's the colistin, which is having the antibacterial activity, and CMS as such doesn't have the antibacterial activity. And the precise mechanism of this polymyxins is also unclear, and it is proposed that the positively charged polymyxins get attached to this negatively charged lipopolysaccharide of this gram-negative bacilli and cause disruption of the outer and inner membrane, leading to the bacterial lysis. And modification of these targets, that is a change in the phosphate groups of the lipid A and loss of lipopolysaccharides, will lead to resistance against this antibiotics. Coming to the timeline, 1947 they were discovered, and in 1960 they were approved for use in the human and veterinary medicine, and in 1980 because of the toxic profile they were withdrawn from the market. And after 2000, because of the lack of newer drugs and development of superbugs, this polymyxins re-emerged into the market. And these are the various resistance genes, polymyxin resistance gene A, gene B, and then this genes and the enzymes which destroy the colistin were discovered in the timeline. And these are the enzymes. So in humans, there were many. This is the mobile colistin resistant gene 1 and mobile colistin resistant 4 in Acinetobacter, including Salmonella and some species of E. coli and Klebsiella. They were discovered. This shows that the drugs are developing resistance against this antibiotic. Coming to the antibacterial spectrum, so this covers only the gram-negative aerobic bacteria, and this doesn't cover for Proteus, Providentia, Burkholderia, Serratia, Moraxella, Helicobacter, Campylobacter, Vibrio, Brucella, Aeromonas, Morganella, and Edwardiella, and it doesn't act against any gram-positive organism and no activity against gram-negative cocci or anaerobes. And coming to the susceptibility breakpoint, both the ES, UCAS and the CLSI, they have different opinions together, and as we all know, there is no definitive breakpoint for our susceptible breakpoint for colistin, so it has to be reported as only intermediate, and there is no formal breakpoint for polymyxins. It is taken as resistant, susceptible to colistin as susceptibility to the polymyxin also. Coming to the PKPD parameters of this drug, it has got very poor oral absorption, so it is used for gut decontamination when taken orally, and it has got very poor distribution into the CSF, biliary tract, pleural fluid, and joint fluid, and these are readily dialyzed. So this makes a problem for use in patients who are on dialysis. So, and after inhalational route also in patients with cystic fibrosis, it was seen that there was only very mild rise in the serum levels of this colistin. And moreover, this complex nature of this pharmacokinetics is because of the inactive prodrug form which it is being administered. And this colistin methane sulfonate has got no antimicrobial property. It has to get converted by hydrolysis into the colistin, which is the active form, and that is having the antimicrobial activity. And there is always how much amount of CMS is being converted into the active colistin, and how much of this CMS is being cleared through the kidney. There's an active, there is always competition going on. So most of this CMS is getting eliminated before it gets converted into the active colistin. So in this study, they have seen that when they have serially drawn levels of cholesterol and TDM was done, approximately only 20% of the sum of the prodrug plus the active form was seen as active cholesterol in the blood. So the both cholesterol and the active and the prodrug form, they get filtered in the glomeruli, but only cholesterol undergoes extensive tubular reabsorption. So, and this will this is eliminated by some non-renal mechanism. But the CMS, which is the prodrug form, it is extensively secreted into the tubules and primarily eliminated in the urine. So, and it is shown that it has got rapid concentration dependent killing against these organisms with a minimal post antibiotic effect. And after the administration of the drug, and there is a second growth curve of the bacteria which is seen within 3 hours, most probably because of the heteroresistance. And these drugs, they also have an inoculum effect. So when there is a increased load of the organism, so the drugs also become ineffective. So another point against this cholesterol use is having a narrow therapeutic index, as we all know, and sir has also mentioned. So we can see this, the red part of the graph indicates the toxic levels, and the blue part is the inadequate levels, that's the below MIC. So if you are giving every dose, so every dose reaches to a level where there is some amount of toxicity. So the therapeutic index is very low, so that every dose is having a cumulative nephrotoxicity, and this is going to be more dangerous on a long run. And coming to the doses and the drugs, how we administer about this cholesterol. So we can see there is a jargon of so many units and so many alphabets, and which makes us so confusing. And even the loading dose, the recommended loading dose was 9 to 12 million international units, and the maintenance dose of 0.5 million internationals twice a day, or 3 MIU 8th hourly. And this has to be modified as per body weight and the creatinine clearance, or the serum creatinine. And most of this European and the American guidelines also have different doses as per the weight. And even the cholesterol dosage and the recommendations vary from the brand to brand. So it is advised that they have to stick to the same dose. And coming to the other difficulty part in using cholesterol is its role of TDM. So in this study, which was published in Microorganisms, where they have analyzed 779 samples from 8 various ICUs, and they saw the cholesterol levels, and the results, the CMS levels did not correlate with the cholesterol levels, and over or underdosing occurred regardless of the renal function and the mode of renal replacement therapy. And cholesterol elimination half time was longer when compared to the previously reported one. And this concluded that following those recommendations, most current guidelines do not necessarily lead to the adequate cholesterol plasma levels, and that's why TDM has to be used for seeing the response to the cholesterol. The another issue which many of us are not aware is the presence of heteroresistance. So heteroresistance is small subpopulation of the organisms in a culture where they are having resistance, and other part of the growth same culture is susceptible. So what happens is, when this population with both the resistance is exposed, so those which are susceptible, they get killed, and those which are having resistance now will start flaring up. With this second growth curve, so the mostly those organisms will grow up, and this will lead to increased resistance. So this will lead to the problem, because initially it will be showing as susceptible, and later if we again repeat the cultures, it will show as resistant. So these were some studies which were done, which I could get from the literature. So this is a study which was conducted in America in some hospitals, where they have they have screened 408 isolates for cholesterol heteroresistance, which are carbapenem enterobacterial, and they have seen that cholesterol heteroresistance, which was detected in almost 10.1% of these isolates. So another one study which was done to see heteroresistance of cholesterol among the carbapenem resistance Klebsiella pneumoniae. So in this population also, we can see there was almost 72% of the
strains which were isolated showed colistin heteroresistance. And the another study which was conducted in Egypt. So here also we can see that when they saw the out of the 115 Enterobacter isolates, almost 17 isolates, that's 35% of these carbapenem producers were also having colistin heteroresistance. So we can see all various gram-negative groups. They are also having various degree of heteroresistance, which will pose a problem in managing. So the other part, we all know they have been withdrawn from the market because of their toxicity. And one main toxic is the nephrotoxicity, and is the it varies from 17% to 60% in various studies. And then we can see the independent risk factor was the minimum colistin plasma concentration, a plasma concentration of about 2.2 micron per liter, which is the one which is required for the, at times it is the MIC is 2, but within just 2.2 levels it can it causes nephrotoxicity. How it and this nephrotoxicity is seen as early as within 2 days of initiation of PrEP, up to and maximum it is noted at after 14 days. How this nephrotoxicity occurs is
Dr. Hari, you are crossing the time. Please.
Yes, the last slide, sir. So this colistin, it's extensively absorbed from the megalin and the intestinal peptide 2 and causes mitochondrial dysfunction, which will lead to necrosis of the tubular cells, leading to nephrotoxicity. And the colistin also causes degeneration of axonal degeneration and demyelination, leading to even neurotoxicity. And the other factor is the cost factor. This colistin, if you are using the present cost which is available in the market, the loading dose costs around 13,500 and the maintenance dose per day costs around. So this is a 27,000 per day, is a very huge burden, along with the cost of the TDM also. So to conclude, because of the high toxicity profile and the ability to achieve the PKPD targets and undefined optimal dosing strategies and questionable susceptibility breakpoints and underestimated heteroresistance among the MDROs and lack of and this which will lead to the cross resistance to other members of the same group and lack of TDM facilities in all the centers and the financial things. I hope colistin has to be really preserved as a only last resort and not as a thing. And thank you.
Thank you, Dr. Hari Prasad. Please stop sharing the slide.
Yes,
and
yes.
The next speaker is Dr. Santana Man. Dr. Santana, over to you.
Good evening to all. I hope I am audible.
Yeah.
Well, after colistin unfavoring to favoring, we will move to the session. I think why I am telling colistin still, it will be not discardable. You end up the session, you will know. First, we know about this already. He covered some. It will be. I will leave it there. We will go with that spectrum of activity. Spectrum of activity and peak pharmacokinetic and pharmacodynamic of colistin is everyone claiming, but what is that? Already he told like it's covering too much of gram-negative enterobacteria, say Acinetobacter, Pseudomonas, difficult to treat organism. It will cover, but some part of gram-positive organism it won't cover. It all acceptable one, but what is newer BLBLI it's doing, you see that one is, suppose you are doing sulfidogrel, it will cover everything, but other drug you see it's not good for MBL producers and difficult to treat Pseudomonas and Acinetobacter you see other than sulfidogrel it's not covering any drug. Stenotomonas also you see it's many drug it not working. Other thing you see, syndrome is you're going for bloodstream infection or pneumonia, it's community care or hospital care, or you see the spectrum is not good for many drugs, newer BLBLI. These are all the data available for us. So renal safety was going, everyone claiming cholesterol is nephrotoxic, but polymyxin B it's reasonably good drug for renal safe. But you see the other drugs, what is the data? Data is limited only. So Astrinomavibat, and metasolum, everything you see, the data is it's not available. That one is another problem. The FDA is not approved drug. Susceptible data also you see, the data is not available. Where is data? Suppose we are going with the data only, everything evidence-based study now is going on. Dosing that is not based on cholesterol is everywhere. It will be not for fixed dose. It will be based on the weight-based therapy individually. It will be better you go for that one Stanford app. It will be cholesterol dose calculator. It will be better useful for everyone. The clearly given dose how much you will give based on weight, based on EGFR. It will be given everywhere. Stanford app. It will be given nicely. If you go polymyxin B, it will be fixed dose based on the weight-based therapy. It will be relatively renal safe. No need for any renal failure patient dose adjustment also. It will be not much for failure. You go for pure BLBLI with cholesterol, it will relatively, the studies are favoring for BLBLI, or it will be safe for renal safe, only for patients without renal failure. But with renal failures, some hazard ratio go, that ratio is very much low only. But only few studies we have, not much more studies we have. That's why we can't tell safe in already renal failed patient, we can't like it will be safe. Another problem, cholesterol and polymyxin B, your hospital doing that one's correct susceptibility and resistant breakpoint is clearly given by UCAST and CLSI. If we are doing per method, that method is correctly you are doing, that one is problem. Suppose you are doing this diffusion and gradient diffusion, it will be not safe for us. It will go for broth microdilation and agar dilation, you need to go. That one is preferred method. You are doing wrong method. Wrong method means it not good one for you. If you go for resistance PKPD, resistance are relatively rising in BLBLI, but evidence also not. The evidence also favoring for BLBLI also, they have resistance so much mechanism also. If you go data septacillimab better, you go that one, you are not going 100% coverage. Some studies are telling cefiderocol it working for 100%, but Indian studies are not good drug cefiderocol. Their studies are favoring. Another thing is ceftazidimab for non-MBL. MBL means you go for ceftazidimab plus astrironam. Suppose Pseudomonas you go for non-NDM or NDM, it will be not good drug for ceftazidimab. Another thing, acinetobacter, it definitely it won't work. It will be not good drug for acinetobacter. If you go enteropatriaceae itself, so much resistance, different mechanism, it won't good for even enteropatriaceae, not good for ceftazidimab. Resistant mechanisms, you go that newer BLBLI have so much resistance mechanisms, like different mechanism, everything. They studies are telling even newer BLBLIs are not good for option. Ultimate aim is cost. Cost, you are going with cholesterol with newer BLBLI. Obviously, the cholesterol amount is much less. You go that cholesterol cost is $3,000. Suppose BLBLI you see $16,000. Only the problem is cholesterol is nephrotoxic, but acceptable. But you go with polymyxin B relatively safe for renal patients. It will be better option for you all. Everyone blaming cholesterol are not good drug, but you are using inappropriate dose and suboptimal therapy. It will be not good option for all. Another thing, there is suppose you are going with enteropatriaceae itself, so much resistant mutations. There is Pseudomonas and Acinetobacter. You go, but is many places non-availability of newer BLBLI, but that's why you use cholesterol is optional drug. They telling, but studies are there is not much more data for newer BLBLI. That's one problem with our studies. If you go with like the way every problem we can ESBL, AMC, difficult to treat Pseudomonas and grab, you can't go with newer BLBLI. If you go cholesterol, it will work maximum time. It will be more time. It will be work. Very less time. It will be unlikely. It will work. There is go with astrinomab, but cephalosporin but a monotherapy can't work for MBL producer. That one's problem is that cephalosporin they selling like it will be pan drug, but it again in the Indian data are unfavoring for cephalosporin. It's not good drug for us. Cephalosporin desafectam it's hydrolyzed by carbopinamase. That one's main problem. If you go imipenem relapactam, it's now clinical data for bloodstream infection. That one's problem also there. Meropenem averbatum, obviously there is so much resistance against mechanism, MBL producer and AXA and MDR pseudomonas. That one is not going to work. If that much problem with our data are telling newer BLBLs are not good drugs. Finally, I'm going to tell that cholesterol is still a better option. I'm telling that. Thank you, sir.
Yeah. Really a good discussion regarding the discard as well as indispensable use of the colistin. Dr. Hari Prasad, do you want to say something in rebuttal?
Yes, sir. Actually, we as Santanam has compared its role against the other newer BLBLI combination. But actually, we have to see cholesterol. If you are using also, we have to use it along with the other drugs because there are multiple mechanisms of resistance in this organism. So usually one drug might not give a good response. So we use a combination, and we have to wait for we have to see for the other 2-3 drugs. So this is actually having a compounding effect on the toxic profile. And as usual, all these patients, we are using this as a last resort where they are already having some amount of renal compromise and neurotoxicity. Most of them are ventilator-bound patients, and they already have. And to see the response is also very difficult to monitor the toxic profile of these patients. Is this the toxic profile of the drug or the disease progression? So it's very difficult. So that's why we'll have to see with the TDM. And that is also adding to the cost factors to these patients, and that is one thing. So if we can, we have availability of the other drugs, so we can try to avoid this cholesterol. That's the only thing.
Thank you, Dr. Hari Prasad. Dr. Santanam, do you want to say? Yeah.
Yes, sir. There is BLBLs are now coming, sir, but data, where is data for that one is there, sir. For PKPD, pharmacokinetic, pharmacodynamics, it will cover all organisms. It will work for bloodstream infections and pneumonia. That one's also issues there, sir. Another thing, main problem, money and availability. That one is issues, big problem in India, like our countries.
But cholesterol, because the only 20% of the active form of the cholesterol is there in the blood. So most of it is being excreted as the prodrug itself. So you are using such costly drug and only 20% is effective out of. So you're wasting 80% of that money.
Yeah.
But newer will be like still now we can't tell. No? That's one data is.
Yeah.
But
yeah,
we can prefer the other polymyxin, which has got a good, and cholesterol as such is recommended only for urinary tract infections. But when managing other things, polymyxin B is more preferred when compared to this. So this is the only message which I wanted to say. We can use more of polymyxin B. We have to promote usage of polymyxin B when compared to using the same cholesterol, just because labs only test for cholesterol susceptibility and they report. And actually we have to know this thing that the susceptibility is equal to polymyxin B and encourage polymyxin B usage.
Yes, a good discussion. Or in conclusion, we can say only for the CRE, especially non-MBL like OXA, 48 and KFC, we have a newer BLBLI ceftazidime avibactam is going to be effective very well, and all the guidelines and guidance are coming in the favor. But we have scarcity of the newer drug and drug used for management of these XDR and DTR organism. We left only these polymyxins E or B for the management. Definitely, we should use polymyxin B over the colistin because of the better PKPD profile of the polymyxin B over the colistin. But as we discussed, for the UTI, colistin is the prefer. And in crux, we can say for the carbapinamase resistant Acinetobacter baumannii or the DTR pseudomonas, we have only the available therapies colistin and polymyxin. But for the CRE, we can select either polymyxin or colistin on the basis of the type of the resistance on the organism. So we have to decide again to case basis. Thank you. And thank you very much. So we will, I will share again, and we will going to our today's last topic of the debate is so we need the response at the post debate response we'll waiting, and after that we will go with our last and final topic or today's controversies in IDs, metagenomics. The is it best way of the ID or a long way to go? So we will have before debate discussion, then I will introduce the speaker, and at the end we will have again poll after the discussion. So we'll ending this poll, and most of are in the favor that colistin is still indispensable. Yes, definitely. We have very scarcity of the drugs required to manage these DTR infections. And I request you to give the pre-debate poll regarding the metagenomics. The best way of the ID is here, or we have to a long way to go? Definitely, metagenomics is adding a lot of advantage over the diagnosis, but there's always difficulties in interpreting in the various patients and various samples. So I think this debate will solve many of our problems. And I'll ending this poll. Yes, audience are in the favor of 50-50. So for this discussion, our first speaker is Dr. Rahul Garg, and he is working as the senior resident in Department of Infectious Disease at AIIMS Raipur, and he has published more than 20 publications in international journals and the books, and he received outstanding abstract award in AMS Microbe 2019 San Francisco, and received several grants and awards to attend the national and international conferences. And he's going to speak in the favor of the metagenomics. Is the best way of the IDs here. And our second speaker is Dr. Yash Katur, and he is pursuing a DM infectious disease course at the AIIMS Jodhpur, and within a special interest in neuroinfections and FUO and fast therapy. And he was assistant professor in internal medicine at Dr. SN Medical College, Jodhpur. So I'm stop sharing, and I request Dr. Rahul Garg to share his presentation.
Good evening, sir. Can you see my presentation?
Yeah, Dr. Rahul, please proceed.
Can you can hear me clearly?
Yeah.
Okay. So good evening, everyone. So the debate topic the given to me is the best of ID is here or a long way to go. And as the pre-poll shows, it is a 50-50 which is going on. So in next 10 minutes or few, I will just go about how to go sequentially. Just a minute. In terms of the pro, that is the best of ID of metagenomics is here only. So before that, a disclaimer, as my opponent is also here. So we are all facing AMR, and the real world challenge is anywhere who is working in the ward or the ICU knows that it doesn't matter what results you bring to the treating team, then only they will only discredit only once the patient is clinically improved and they feel comfortable. So we are all engaging with the clinicians and various departments for changing their ideas. So in this PPT also, I will try to change your ideas that the metagenomics is here only. So my plan is to talk about the background and the testing landscape, who and what, talking about the focused review of literature and the clinical impact assessment. So metagenomics, as we all know, it is a study of the collection of genetic material, whether RNA or DNA. In terms of RNA, it is known as the transcriptomics, from a mixed community of organisms, both the microbial and the host. The capacity to detect all the pathogens, bacteria, fungi, virus, and the parasites in one sample and simultaneously integrating it to the host response is a great achievement in the field of ID. So in terms, it can be tell us it is a one-stop shop where you can test all for all the parameters in the infectious diseases. So why do we need the metagenomics in the clinical setting? That is the big question. So we all know the culture negative part that comes day in, day out in our clinical part whenever we are in the IPD, OPD, or in the ICUs. So 80% of the encephalitis or the meningitis, 60% of the various pneumonias, whether it is community acquired or the ventilator-associated pneumonia, and the 40% of the sepsis patients results in the negative cultures. And thus it results in the extended ICU stay, increase of the infective uses, and increase the cost per se, both for the hospital and the patient per se. So we all know the culture techniques which are being used conventionally. They are time consuming, effortful, and if we are delay and we are using a multiple techniques, then it will add towards the cost too. So the metagenomics is a part which is culture independent, a target independent, and not affected by the prior antibiotic use. That's it's called a one-stop shop. So what happens? Whatever is the specimen we are using for the treating per se, we are processing it and we are extracting the DNA or the RNA, whichever is feasible, and we are doing the metagenomic sequencing on that nucleic acid extraction, and it can be either a 16S gene-based metagenomics or a shotgun metagenomics. Now the shotgun can be a short read or a long read. It depends on the data which is available in that process. And then we do the data processing, and then the annealing and the binding and the assembly, and then we go for the interpretation part based on the bioinformatic analysis. So what is the clinical applications of the metagenomic sequencing in the ID world? It can be used for the microorganism identification. It can be used for the antibiotic resistance prediction, as we have seen a lot of antibiotic resistance genes which are been coming day in, day out because of this metagenomics. It will tell about the variance determinants basically, and it can tell about the antiviral resistance predictions mainly in the HIV and the hepatitis B and C patients. It can also be used for the microbiome analysis, both having the healthy individuals and the patient that can be used, and it can be used as a part of transcriptomics. Here you can see, here we are not determining the infections, but we are using the host response to that infections that can be there. So in the red bar, you can see the host response to the infections in the positive side. And in the negative bar, you can see the blue color, that is the no infections in the host that can be there. And towards that, we can generate a heat map also, which can tell about the various genes that can be inducible or the suppressor genes can be there. So in per se, the metagenomics detects various pathogens, whether bacteria, fungi, parasite, or virus. It can detect the antimicrobial resistance prediction, virulence factor, epidemiological studies. And the benefit will be, it will help in the targeted treatment if available, discontinuation of the empirical therapy, avoid invasive procedures, and help in the global health measures. Overall, it also reduces the cognitive burden on the clinicians to think all the possibilities in the ID field that can be there in these patients. So metagenomics is not like finding a needle in the haystack. It is basically more realistic. It is like if there is a needle, we have to find it in the haystack. So coming to what can be the utility of the metagenomics. So for any test, whether it is metagenomics or a PCR per se, we should know what can be the testing population, what is the patient presentation, symptoms, and the time of the sample collection, the quality of sample, the location, the type of relatability, and the performance which is pursued in terms of the analytical and the post-analytical phase. So coming to the target populations where various metagenomics has been done and is been doing good, is in per se in the immunocompromised patients, the CNS infections, the sepsis, basically the endocarditis part. As you have seen in the due criteria, also they have included the metagenomics part. In the prosthetic joint infection, the FU, where the patient has with a lot of diagnostic tests, and per se it comes all of them comes sometimes negative, and the patients who are on empirical treatment. So my colleague can say, we are doing so many tests, but what are the performance characteristic and the diagnosis condition which can be there? So these can be the in terms of his argument variability of the sensitivity. So various literature till now have been shown that this metagenomics has been have good sensitivity, specificity, and a positive predictive agreement that has been there. Various statements in the forms of review article or the case reports or the RCTs has been done, which have shown that tissue infections in the joint infections, the pneumonia, endocarditis in the FUO, sepsis part and the meningitis, and the ocular infections, it has been sensitivity of more than 80%. So coming to one by one, a few of the cases which I will discuss. So in the part of the CNS infections, as we all know, 50% of the CNS infections, the etiology and only unknown. There is a limited sample which we have to test in parts of the lab side. And there is a various pathogens which can be there presenting or mimicking the CNS infections, starting from the bacteria, the parasitic, the fungal, or the viral part. And there is be unprecedented pathogens like the astrovirus in the immunocompromised patients that can be there, or the novel pathogens can be there like the adenovirus. This is the first virus which was detected by the metagenomics in 2008 per se, and till here we have came out. In the part of the bone and joint infections, you can see the sensitivity in the monomicrobial samples, it's up to 100%. In the polymicrobial samples, it goes down relatively to the 58%. My colleague can also argue that yes, we have the good sensitivity, specificity, accuracy, but what happens in the real life settings? So what happens in real life settings is to be detected by the reduced time to appropriate optimal treatment, reduced hospital stay length, the healthcare cost, the various tests which has performed cost, and the reduced mortality and morbidity. So if you see all these studies, if you see the definitive impact and the main finding, you will see the impact of these studies was in the management decisions that was there. And around 80% of the metagenomics results were clinically relevant, and the patient was started on treatment because of this metagenomics results, and 14 has the utility too. There can be the quantitative result interpretation also, basically in the part of the definitive or the asymptomatic infections which can be there, or in the part of the relative organism or the irrelevant organisms can be there. So this can be also done by the bioinformatics part. So coming to one of the such study where we have done the metagenomics in the encephalitis and meningitis patients. So this was the 1 year prospective study, the 58 CNS patients, where 22% was not identified with the routine clinical testing, and the mean TAT was for the metagenomics was 90 hours, which is far less than the conventional testing which is doing. The sensitivity was 80% and the sensitivity was 98%. Coming to the another study, which was very crucial in the critically ill culture in negative metagenomics in the CNS infections, the 42.7% patients has been infected with the non-cultural pathogens which are there, including the viruses. This study was done in per se from the India, the whole genome enrichment approach for the detections of the MTB and the drug resistance. And they have shown that the metagenomics has been 100% sensitive to the resistance variants of towards the LPA, and have been detecting far better than the phenotypic test. Same results was seen in the comparison of metagenomics from the MIGIT or the modified GEN, and you can see the specificity up to 100% and the predictive value up to 100%. Coming to the prosthetic joint infections, again, it is mostly bacterial, but some of the fungal pathogens are per se, and it continues to be in a pathogens range that can be there. So again, this is the systemic review and meta-analysis which have shown the sensitivity up to 93% and the specificity up to 95% that is there. And they have detected in this study, they have shown that 54% culture negative PGIs was being detected by the metagenomics and 90% of the culture positive there. Again, in the part of normal pathogens, we have all seen the coronavirus, how it's been detected in the chikungunya virus in the Bangladesh, that is the Zika, and the chikungunya virus in the Brazil. And this was one of the study by us, which has been shown the community transmissions of Omicron, and the first case we have detected in Delhi per se when the Omicron came, and how we decentralized the population there. This is the per se, the infection control part, how can it be used? So this is the very good study which has been done, the real-time genome sequencing, basically for to see the MRSA, VRE, MDR, E. coli, and the MDR pseudomonas. The TAT was up to 4.4 to 5.3 days, and see the cost deduction which have been done up to 2 lakhs in the study period that has been done. So the rational approach will be towards the fastidious organism or the culture negative patients in the immunocompromised host, in the patients which are of endocarditis, encephalitis, or the PGI, in the outback investigations, and in the sentinel surveillance program. Thank you.
Thank you, Dr. Rahul. Excellent presentation. I request you to stop sharing and yeah. Now, Dr. Yes, over to you.
Thank you, sir. Am I audible?
Yes.
My screen is also visible, I hope.
Yeah,
So,
make it on slideshow.
yeah, just a minute. So, metagenomics in ID is a technology yet far from home. Good evening to all. I wanted to start my topic from our ancient legend, that is the story of Ashwathama. It's a very good story which says that we should always know what we are doing. So Ashwathama was a great warrior, and he could use a range of weapons, including Brahmastra. So once in Mahabharata, he logged in duet with Arjuna, and both of them used Brahmastra and Brahmashira against each other. But on the recommendation of their gurus, because of the devastation they are going to do on the earth, they decided not to use it. Because of the lack of knowledge, Ashwathama couldn't retract his weapon, and he had to use it on an unborn grandchild of Arjuna, inviting a great curse of leprosy and eternity to live afterwards. So my point is, if you don't know, don't act. You should always be aware of your deeds, what you are going to do. The question is whether metagenomics is Brahmastra of ID. Is it the best of ID? Then I beg to differ. It is not the best of the ID. It can be part of the best of the ID. What is the best of ID? That is meticulous history and examination, thorough ID knowledge and training, stewardship practices, which include both diagnostics and treatment. So here is the thing where metagenomics come into the picture, the stewardship, diagnostic stewardship, so that right test should be prescribed for the right patient. And why to stop at just at metagenomics? We need to innovate novelty at a regular basis, the technologies which is acceptable to all and are cost effective as well. And yes, obviously we need collaborations with other departments. I think just depending upon the metagenomics, without fulfilling all of these things, we can't bring the best of ID in our country. Long way to go. We need to ask several questions. My friend Rahul cleverly ignored that the data is not much available for the countries, developing countries like India. Many of the studies which he has shown was from the West, where all of these questions are already answered. Let's say conventional resources, appropriate guidelines, expertise in bioinformatics pipeline, cost and benefit analysis and interpretation, that is implicability of the metagenomics, and obviously to control the corporate greed. So I will take this point one by one. So conventional resources at place in our country, the ground reality in our hearts, we know that it is not there. Most of the laboratories and most of the medical college, which are supposed to be the tertiary care center, do not have basic microbiology technologies, even culture, I would say, rest alone this Vitec and Malditoff, which are time-tested technologies and increasingly used in good hospitals. There are multiple literatures which suggest that, and we have already seen in pandemic where there was clearly the shortage of infectious disease specialists. So there was lack of manpower, lack of technologies and infrastructure for basic microbiology. The basic microbiology also includes the stewardship practices. So there is improper diagnostic and management guidelines and poor policy regulation. So by the time patient arrives to an ID consultant or a hospital with proper microbiological technologies, we might have lost substantial opportunities to diagnose the case. Even the simple cases, because of the use of empiric and unjudicious use of antibiotics and antimicrobial, can be missed because of uh, uh, inapplicability of the stewardship practices in our country. So my point is that focus should be more in implying and applying all of these things first, and then shift to the metagenomics. The studies in abroad have already utilized their conventional microbiology, and they use this metagenomics to supplement their conventional microbiology technologies, not to supplant it. And, it is easily said and done that metagenomics required a lot of expertise. It is not so easy science, right from the specimen collection to specimen handling, DNA extraction. It requires a lot of steep learning curve and expertise, training and retraining, which is not yet visible in our country. And obviously, Dr. Rahul has done a great job, and I wish more and more doctors like him will be appearing in the near future in our country. Having said that, bioinformatics is a base of metagenomics, at least what we say the shotgun type of metagenomics. It is already an underserved data science in our country, and we need bioinformatics so that we may have a genome library which can differentiate between friendly microbiomes and human genomes from that of pathogenic one. So that is very much important, and we need to create libraries. And definitely anyone can understand that this thing is far-fetched as of now. We have had the opportunity to use metagenomics in past 1 year, and our personal experience, and I think anyone can agree that as of now, it is not a pocket-friendly investigation. And in country like India or any developing country, the cost has to be taken care of, because we can't blatantly keep on prescribing such kind of investigations. So just identifying the kingdom of genus, say whether the pathogen is bacteria or fungus, we need some 3,000 to 10,000 rupees of costing. And as we identify the genus, we have to precisely identify the species and a particular pathogen. Then it will further increase the cost, which may come around 15 to 20,000 in most of the cases. And we have to admit that as of now, most of these technologies are present in metropolitan or in big cities. So distance and transportation charges are also added up. And by the time patient arrive to us, they have undergone already so many tests like MRI and other high costing investigations. So it is quite an economic nightmare for the patients. And even after you get the results, the question is asked, so what? Maybe the pathogen is there, maybe the organism is pathogenic, but it is not causing the pathogenesis in your body. This is called as principle of presumption of innocence, that just mere presence of an organism at a particular place cannot prove its guilt. So as I previously told, convention can be supplemented but not supplanted. And there is still the lack of high level evidence of utility of metagenomics. It's developing, but as of now, especially in country like India and developing country, developing world, where we are trying to implement all of this metagenomics technology, the data is not so robust. We even this article was published in Journal of Clinical Microbiology, where they are also saying that still we need to prove that it is still this technology is useful or not. So they have advised the utilization of value metrics best practice, in which whatever hospitals who are using metagenomics, they have to input this data in this kind of value metrics, and to determine whether it is working or not. Case-to-case basis and case reports can be there. There can be many case reports, but that isolated cases cannot prove the general applicability of the metagenomic technologies. And the work is not just done when we identify the pathogen. Even after modification, we have to revisit the diagnosis sometimes. It is a cyclical process. You get the result, you identify the organism, you modify your treatment. If treatment is not applied and clinical outcome is not achieved, then we have to revisit the clinical diagnosis. Maybe the second and third organism which is identified on the metagenomics has to be given credit or for the pathogenesis in our patient. And we may have to relook for the other organisms by using the same metagenomics technology, which can again further increase the cost. I also want to emphasize that capitalism is quite rampant in our medical field, but we need the right kind of capitalism, not the crony one, where just for the benefit, the pharma industries, I will not name it, even the doctors and sometimes patients themselves undergo such kind of investigations, and there is a huge market running behind it. So we can take the example of MRI. When it was not easily available, it was not prescribed so much, but now even for simple back pain which is lasting for 1 or 2 days, many doctors and many laboratories are prescribing MRI scan, and even if you get the results, it can just increase the diagnostic dilemma if you find any anomaly which can be attributed to the disease or not. So we have to control the corporate greed also, and it is very important. So this slide emphasizes the many problems which we are going to face when we are using the metagenomics at all the levels of healthcare in our country. I want to emphasize on the bioinformatics analysis, where you need computational power, misaligned sequence. So whatever personnel and people we are training in metagenomics, the learning curve is very steep, we must admit. And most of these patient personnel should know that where they are going wrong. They should be able to identify the error, and will take a long period of experience. So definitely this technology is still far from be generalized. I must add it. The Lancet, this article was published in Lancet, and they made a case for investment in clinical metagenomics. In this article also, they never never prescribe this test we use in day-to-day practice. They advise that there should be a focus on capacity building, and we must know the local microbiome, so that at least what kind of bioinformatics information needed to be applied for the final result should be known. This metagenomics can be used for epidemiological analysis, as Dr. Rahul already explained that they identified some novel variants of COVID. So yes, that can be used. So there can be some prescribed laboratory, central laboratory where it can be used. I'm not denying that. But the question is whether it is already like our ID is ready to use it on day-to-day basis. It can be helpful in difficult cases, obviously, helpful in cases with high stakes, which includes like prosthetic and joint infection, patients with transplant, where already so much money and skills of doctors has been already tested. At that time, you can use that is justified that we can spare some extra expenses for identifying the organism. So all these technologies and all should be there at particular hospital, and that can be utilized step-by-step manner, and then can it be generalized. So I have what I have read and understood. I have made a very simple.
Yes, you should be fast.
Yeah, sir. So this is the algorithm which can be used. I have already explained. If anyone find any confusion, I can discuss it on personal platform. So to conclude, there is a long road ahead. The first focus should be to develop the conventional diagnostics. Second focus should be to develop experience and expertise. Third focus should be on the cost effectiveness. We should make it pocket friendly, and so that it can be useful for all and sundry. Fourth focus should be the stewardship practices, and we must assess the applicability of any of such new technologies. With that, I conclude my talk. Thank you.
Excellent, Dr. Yes. Dr. Rahul, only 1 minute rebuttal because of the shortage of time. You can say 3 words. Yeah.
Sure, sir. Yes, can you just stop sharing once?
Just a minute.
Just a second. Just a minute, sir. So thank you, Yash, for agreeing on the part that metagenomics has been used and is being used in the difficult cases. There is no wonder, and you can get your answers from the audience which are giving their chat in per se in this Zoom. They are all agreeing that yes, metagenomics is here. What I can see in the chats. So whatever I understood by the arguments of the Yash, it was basically on the front line or the last line metagenomics, the bioinformatics, the infrastructure, the lack of knowledge, the stewardship. So I want to ask all of you, how much you have paid in the COVID-19 testing, or while there was an outbreak, or while in the TB testing by the patients or by yourself only. So yes, has been shown this case of investment in the metagenomics, and yes, fully agreeing that it should be metagenomics should every test, not only metagenomics, should be used rationally in terms of the diagnostic stewardship, whether it is being used in the low middle income country or the high middle income country. So just showing of the cost benefit analysis. So this is one of the study which yes didn't read or I think didn't see. So this is one of the excellent study in the FUO cases. We all know that FUO cases are very challenging and a lot of been invested in the FUO cases. So this is a pragmatic study to see the cost of the clinically relevant strategies in the tool making. So they have planned various designs. Excellent study, I must say. Everyone should read this. So one is the conventional workup, one is the NGS supplement with the laboratory test, and third is the NGS supplement with the imaging test, that the CT scan which has been done. And you can see the break-even analysis of this baseline scenario. So you can see the blue line is the baseline, which is the cost which is there. And you can see how the metagenomics has helped in the cost saving if it is being used as the first line in the FUO cases, and if otherwise it has been used as the second line or the last line in the cases. So here also you can see how it has been used. Up to 98% cost saving have been done. Second thing about the infrastructure, yes, we all know that there's a INSAGOG and AIMS Jodhpur is also a part of that. And there are various institutes which are there per se. So they are all being using this metagenomics in the COVID testing or the influenza testing, which is there. So there is an infrastructure that is there. We have to just utilize what test, what time, what for what patient has to be done. And by our honorable minister for the TB testing, also the whole genome sequencing has been applied for in the TB genomic surveillance consortium that has been there. And there are various institutes which are been part of this also in the genomic surveillance, and they have recently made this catalog also of the mutations with the drug registration 2022 in the India. This is something proud because of the metagenomics part which is there in the India in the low middle income country. So the way forward, as the yes told, yes, the stewardship has to be there, whether the clinical stewardship or the diagnostic stewardship. We should know what patients we want the test for, any test per se, that should be there. Per se for metagenomics, we should know what populations which can be there based on the literature that is there, mainly in the immunocompromised or the endocarditis or the prosthetic joint patients, and what should be there to done in the negative culture reports that has to be there where the metagenomics has to be applied. Thank you.
Sir, I just want to reply to Dr. Rahul. I hear you, Dr. Rahul. Excellent talks, definitely. But the studies, most of the study and last study you have shown is not from India. I personally, being a clinician, I know that most of the stewardship practices and basic microbiology technologies are not available. And even the simplest cases are missing because the culture is not available. So first, we should keep our house in order. The basic things should be fixed. Obviously, there are many things, and what you did in COVID cannot be equated to the whole metagenomics, which is a shotgun and shotgun technology, one part of it, which needs the backing of bioinformatics. So believe it or not, bioinformatics background is not so much available as of now, and there is still a long way to go. With that, I rest my case. I hope we are done, sir.
Yeah. Thank you. Thank you. Yes. And thank you, Dr. Rahul. In conclusion, I can say no building can be made without any base. So you should have a strong base, then you can make a strong multi-story building. So we should have a strong basic microbiology support. And after this strong basic microbiology support, if we are not able to get the diagnosis, we should utilize this next generation sequencing and all these metagenomics to stabilize the diagnosis, because it is sometimes life-saving in around 20 to 25% of cases, which we are not able to diagnose even with the best of our available microbiological support. So definitely we require both the basic as well as the advanced meant of these metagenomics for the diagnosis of the cases. Thank you, Dr. Rahul and Dr. Yes, and I will start next the post debate poll. After this poll, we will. So it is post debate poll. So I sorry. Yes. So I request everyone at least to vote in the post-debate poll. So I am ending the poll. So definitely we require the metagenomics, but regarding the financial condition of the patients and our country and available resources, definitely there's a long way to go, and audience is also in the favor. Thank you all, and I think it is a very good controversies of ID debate, and we have completed this debate very successfully. Over to you, Dr. Akshatha.
Thank you everyone for joining. And yeah, because of the initial extra 15 minutes, I think we exceeded by a few minutes. So I hope all of you had fun, and it's a different way to learn. So we are exploring both the sides through this debate. So that is why I wanted to have this. So yeah, but as you end the Zoom, once you leave, please give us the feedback so we can plan further sessions accordingly. Thank you everyone. Have a great. Thank you, sir.
Thank you. Thank you, everyone.